Thank you very much for the introduction, Colin. So we felt that talking between the two of us would be very useful for atrial fibrillation. Part of that is to try and gain the combined wisdom of the two of us, and also to have the idea that atrial fibrillation, as Colin has mentioned, has become more complex. There's more things to think about, and so to have two of us talking about it and thinking about it, I think will be helpful. And we've got three cases that we're going to hinge our thoughts and discussions on when we talk about this. The other thing you'll notice is Ruvin is holding his iPad, so if you have questions during the talk, please do feel free to send them through. We'll try and answer those and incorporate those into our discussions as well. So please, by all means, send questions through. If not, we'll answer at the end as Warren and Jamie previously have. So.
Okay, so let's go through the first patient, a 66-year-old gentleman, Mr. B. He's experiencing rapid and irregular palpitations, perhaps for 6 months, similar sort of symptoms. Sometimes it occurs during exercise, lasting several hours, the longest being 2 days. Sometimes having an uncomfortable feeling in his chest during the episodes and a reduction in exercise capacity. Between episodes feeling completely well, taking no regular medical therapies, a regular pulse, and the ECG shows atrial fibrillation with a ventricular rate of 130 beats per minute. So Andrew, I mean, this might be a typical patient who might turn up to your practice. You know, what's going through your mind about what you would do if this patient turned up to a general practice?
Yeah, well, the first thing I'm thinking about for this patient really is, well, they've come along with symptoms, so they have a problem. But I think the mainstay here is to do what you've already done, which is identify and make a diagnosis for the cause of their symptoms, which in this situation is atrial fibrillation. We're therefore taking a person who has symptoms and aiming to try and improve their symptoms, and I think that's the first step. Subsequently, the next step really is to consider how we might assess the patient, both from what's the cause of this atrial fibrillation, why has this happened, and what's the best way to manage them looking to the future. So when I think about this, in terms of assessment, the first things I'm really thinking about is to confirm the diagnosis. Now, as we've heard, there are a number of causes for palpitations. This could have been frequent ectopic beats, but in fact we've confirmed the diagnosis here of atrial fibrillation. I think a full cardiovascular examination, and here we're really looking for the likes of hypertension, looking for evidence of murmurs that might indicate valve disease, for example, and we're looking for signs of heart failure. Now, atrial fibrillation is a common association with heart failure, and when it occurs in the context of established heart failure is an adverse prognostic feature here. Now, in some patients also, very fast rates for a period of time can lead to tiring or impairment of the left ventricle and lead to heart failure in its own right. So then we think about underlying etiology, routine blood tests and arranging for a chest x-ray. Now, I guess when we're thinking about the underlying etiology and arranging chest x-rays, what sorts of things are you thinking about when you do these, Ruvin?
Well, I think I'm probably, if I organise a chest x-ray, I'm kind of looking at the size of the heart. So for example, if the radiologist says, well, the cardiothoracic ratio is definitely big, then definitely I'm thinking, could this patient have had frequent atrial fibrillation, maybe have a cardiomyopathy, a rate-related cardiomyopathy associated with that? Or it could suggest that maybe there's some underlying structural heart disease that could be, a trigger for that. So I'm thinking about the underlying etiology. Certainly I'll be thinking about those things. I mean, in terms of underlying etiology, we're taking the history about alcohol intake, underlying hypertension. That could be the most common triggers for atrial fibrillation. I'll be thinking about those as well. And then the blood tests, as you say, you've got patients who perhaps maybe have not realised they've got thyrotoxicosis. That may be a trigger for atrial fibrillation, so I'll be thinking about that. Could that have been a cause? And if so, then we'd be thinking about trying to control the thyrotoxicosis if that was the case as well.
Yeah. Great. Now, in this day and age, another cause that I think about more commonly is those patients who have obesity and sleep apnea. Obesity and those lifestyle factors really do drive the likes of diabetes, sleep apnea and things that can be an underlying cause and driver that need to be managed in their own right, and they're important comorbidities that go with these patients. So the next thing that I'm thinking about after this is, well, you have a patient in front of you with atrial fibrillation of onset that's been relatively recent from their symptoms, and we've got a heart rate that's elevated at 130. So I'm thinking, well, gosh, do I need to manage them in an inpatient setting, or should I manage them in the community in my practice, or in your practice? So this is where I start to think about these red flags and start to think about risk of this current episode and how I might best manage this right now. And this comes down to things like chest pain. If it's associated with ischemia, then that makes me much more likely to want to manage them as an inpatient. Clearly, if they're hemodynamically unstable, either with a 3D pulse character or very low blood pressure, evidence of heart failure, those would be much more likely scenarios that would make me want to admit the patient. Clearly, if this is associated with cerebrovascular disease or recent stroke and TIA, I'm concerned about an unanticoagulated patient with recent stroke and atrial fibrillation. These patients are at much higher risk of having recurrent stroke in the near future. If there's evidence for mitral stenosis, now this might be a patient that you know has mitral stenosis or has a definite past history of rheumatic valve disease. These patients are at higher risk of having stroke. Often hemodynamically do much worse when they're in atrial fibrillation, and also those with syncope are red flags.
So Andrew, we've got a question here. At my GP setting, this patient should be referred to hospital acutely if he's symptomatic, even if the blood pressure is normal. I mean, do you agree with that?
I think not all patients need to be acutely referred to hospital when they're symptomatic with a heart rate of 130. I think if patients have presented because of palpitation and that's all that they've noticed, then it would be very reasonable to trial an initial strategy of rate control, so that's a beta blocker or calcium channel antagonist, whilst you're undertaking your initial evaluation. I think a really important step here is to re-evaluate the patient shortly after you've initiated treatment, once you've been able to complete these assessments and examinations. And that might be a few days later, once you've had the chance to review the results of, say, a chest x-ray, blood test, thyroid function and the like, and also to reassess the effect of your rate control that you might have tried initially.
And another question, how much alcohol consumption can trigger atrial fibrillation? Well, I think that's very difficult to answer, to be honest. I think, you can have some patients that drink a lot of alcohol and will never have atrial fibrillation, and then you'll have some patients that, will drink a little bit and it seems to trigger. I mean, what do you think, Andrew? I mean, that's what I've told patients.
Yeah, that's the sort of thing that I tell patients as well. I think binges tend to trigger atrial fibrillation more commonly than regular 3 or 4 units a day alcohol. I think ALAC's recommendations of less than, depending on New Zealand, 20, 21 units, or if you take the European approach, less than 15 units per week. I think if you stay within those general guidelines, you're unlikely to have that as the trigger for atrial fibrillation. I guess we also now need to think about increasing methamphetamine use, and we certainly see that as another trigger for atrial fibrillation in the community. I'm not sure, have you seen other agents such as meth cause these things?
Yeah, definitely. I mean, we've seen a lot of methamphetamine-related cardiomyopathies, certainly out in South Auckland, and certainly some of those patients have presented with atrial fibrillation. That is indeed true.
Yeah, so I think in addition to alcohol, we do need to think about these other agents that our patients are increasingly using in the community. And managing people with meth addiction is really challenging, and it's its own specialty in its own right these days, with addiction services around the region that are evolving and establishing.
What about prolonged coughing not related to COPD? Can that cause atrial fibrillation? That's a question that's come up.
Yeah, I think a number of triggers of atrial fibrillation can include increased sympathetic tones, so that's as this person was with exercise, or also those people with increased vagal tones, so that's often obese patients overnight sleeping with sleep apnea. Coughing, for example, can potentially increase vagal tone and maybe be a trigger, but I guess if somebody has recurrent episodes, then that suggests that they might be prone to having atrial fibrillation, and that had occurred in the context of coughing, might be a trigger on that one occasion. But if it's been a recurring phenomena or symptom complex, then I guess one doesn't just treat the coughing. What's your approach to that?
Yeah, I mean, I agree with that.
Yeah.
I think we should move on to the next component now, and we're talking about management, and I guess some of the questions coming up now, Andrew, are a little bit more about how we're going to manage the patient if they're in your practice. So I guess we've talked about if any red flags, seek general medicine advice. Now this is in the Health Pathways website. I think if you're in the North Shore, if you're in the Middlemore Hospital area, We have a cardiologist answering the phone now during working hours, so you can get a cardiologist advice, so you can ring up the cardiology on call and get some advice on that. And at Auckland Hospital, you've got you've certainly got the
direct admitting through cardiology to the service and the like. So a call through to that service would be very reasonable. I think in North Shore, maybe if we involve Colin, who works on the North Shore, is that still dominantly these patients coming through the medical service, or?
Yeah, mostly medical. Every now and then I get a text message and then handle it through Edie. Yep.
Yeah. But these are the practical considerations to have when you've got a patient in front of you that particularly your practice might cross over these arbitrary health board boundaries in terms of where your patients are living. It is important to think about these things as well, and counties in Auckland do have direct discussions at admitting to the cardiology services, and that might evolve around the region as time goes on.
Of course, you can also ring the Auckland Heart Group and get some direct advice from a cardiologist, of course. So don't forget, you can definitely give one of our cardiologists a call on our Auckland Heart Group line as well. Yeah. So, okay, let's take the patient, maybe the atrial fibrillation's clearly less than 48 hours since the AF onset, and I think, you know, if the patient's highly symptomatic and the patient comes in to you and says, you know, the palpitation started, for example, their first episode had started with an absolute onset, they can tell you, look, the palpitation started at this time, and certainly we can bring the patient in and consider whether the patient would be suitable for a DC cardioversion. Once atrial fibrillation is prolonged more than 48 hours and they're not on anticoagulation, we can't guarantee that you can't have thrombus form within the left atrium or left atrial appendage. And so then we really cannot cardiovert them without absolutely making sure that there's no clot in the heart. And in that sort of situation, if the patient comes into hospital, we'd certainly be thinking about either doing what we call a transesophageal echo, where we put the probe down and have a look at the heart and make sure there's no clot in the heart before we proceed to DC cardioversion. And in some instances, the alternative, those patients, if they're not particularly symptomatic, can be anticoagulated and brought back later to have their cardioversion as well. Andrew, do you agree with that?
Yeah, I do. I think probably the message should be that if a patient's really unwell, in addition to the short period of time, then obviously coming into hospital is the right thing to do. But the more unwell the patient is, the better sinus rhythm sounds. And we can do sophisticated imaging, both transesophageal echo or CT, to assess the presence of left atrial appendage thrombus and undertake cardioversion with a really very low risk of stroke in that setting. And I guess if the patient's critically unwell and potentially at risk of dying, then one has to philosophically weigh the risk of clot, stroke versus imminent potential death if people are critically unwell in that situation. And obviously the hospital environment's the best place to weigh these things.
Okay, and the next point is just consider treatable causes. You know, certainly we've talked a little bit about the hypertension, diabetes, obstructive sleep apnea. You've got to address those underlying risk factors. So you've got to ask those questions. Consider an echocardiogram. I think patients with atrial fibrillation, all of them should have an echocardiogram. Do you agree with that, Andrew?
I do agree. I think it's a very useful modality to, it's a non-invasive modality. It's very useful to assess ventricular size, valve condition that you might manage differently. And I guess those patients with mitral stenosis, and there are segments of Auckland where rheumatic valve disease is quite prevalent. And rheumatic mitral stenosis is a significant comorbidity associated with atrial fibrillation that does often lead us to treat the patient quite differently than those people with completely structurally normal hearts. I guess the group where I might not undertake routine echocardiography is if you have a completely asymptomatic bed-bound, highly comorbid, say very elderly patient that you might be seeing in a rest home environment, then I guess one does need to weigh up whether or not bringing that person out of that environment to do an echo, what the value of that is going to be in an individual patient. But I think for those people who are ambulatory, relatively minimal from a comorbidity point of view, and where that management would change the individual patient's treatment, or where that information would change their treatment, I think it's a really useful imaging technique for this.
Okay, well, let's go on to commencing rate control therapy rather than rhythm controls, and now the main treatment focus. I guess in your practice, if you're going to if the patient's not symptomatic and they haven't got any of those red flags, then maybe the step is that maybe we start some rate-controlled therapy. So one of the drugs, the series of drugs that we tend to use for controlling the heart rate are beta blockers, calcium channel blockers, and digoxin. Now, I think, as Jamie alluded to, there's really some evidence that that our first therapy would be either a beta blocker or a calcium channel blocker, such as metoprolol or bisoprolol, or diltiazem to control the heart rate. I think digoxin has really fallen out of favour because there is some data that's come out suggesting that if you have patients on digoxin and your blood level of digoxin is over 1.2 on your therapeutic range, that there can be a signal towards increased mortality. So we're really trying to limit digoxin to those patients perhaps who have a heart failure. You've got limitations on blood pressure, controlling blood pressure. If the blood pressure is low, in being able to use that medication. I tend to use beta blockers first. I think that's a personal preference. But patients who have hypertension, they've got very high blood pressure, then you're going to get more of an antihypertensive effect that's my personal preference, to potentially use diltiazem in that therapy. What do you use?
Yeah, I tend to use beta blockers first as well, and like yourself, I tend to reserve digoxin for either as combination therapy or where people have bad heart failure, and often don't use it at all these days. I guess that line, the commence rate control, so this is taken from the Health Pathways website, and I think the wording on this is a little bit contentious. I know Dr. Smith, we collaborated on writing some of this a couple of years ago, but I think the main treatment focus, I would say it's an important treatment focus for most patients, but I don't know that it's the main treatment focus for the entire patient population. And I think that we talk about rate control strategy and rhythm control strategy, but I think for an individual patient, that strategy can evolve and change as time goes. This patient that we talked about at the start, the initial strategy or the initial aim here is to get the heart rate under control, but I don't know that a rate control strategy would be this patient's ultimate aim or the ultimate aim for this particular patient. I think for a number of patients, increasingly common, we're thinking about how do we select those people where maintaining sinus rhythm is the most important thing. And I think for those people who are highly symptomatic of their atrial fibrillation, particularly where it's paroxysmal, it comes and goes, I think trying to maintain sinus rhythm improves the quality of life, improves symptoms, and allows people to get back to doing exercise activities that they might otherwise avoid. So whilst I think a rate control strategy is really very important, the main treatment focus, I think, should be patient-centred and should be aiming to improve symptoms, quality of life, and to prevent the effects of tachycardia would be the main goal of rate control. But I don't know that rate control as a strategy should be the main treatment focus for this entire group.
Yeah, I think if patients are particularly symptomatic, and I think your younger patients and they're having a lot of paroxysmal atrial fibrillation, I think we're probably more likely to go for a rhythm control strategy. I think your older patients who are asymptomatic and incidental finding, and perhaps it's quite likely potentially they've had asymptomatic atrial fibrillation for a long period of time, then I think the rhythm control strategy, rate control strategy is better for those patients. But certainly your paroxysmal and your symptomatic patients, we're certainly thinking about a rhythm control strategy. But there has been this trend towards perhaps trying to manage a lot of these patients with a rate control strategy, Andrew. I mean, maybe do you think we've gone a little bit too much the other direction?
I think the trials from a little over a decade ago showing no mortality difference did swing the pendulum much more in favour of a rate control strategy. And I think for some patients that is appropriate. But I think it swung the pendulum perhaps a little bit too far. And right. I think it meant that a lot of people who were highly symptomatic were then confined to permanent atrial fibrillation, where in truth their quality of life might have been better if we had aimed for a rhythm control strategy. Now, the difference in terms of when those trials were done and now is our ability to obtain and maintain sinus rhythm is probably a little bit more nuanced, a little bit better. I think we no longer, in terms of antiarrhythmics, we no longer confine people to high-dose amiodarone for years and years. I think the emergence of catheter ablation strategies as treatment for paroxysmal atrial fibrillation, the highly symptomatic patients, has been really helpful and really useful for a subset of this group. Not a big subset, but an important subset, where people are highly symptomatic with frequent episodes of paroxysmal atrial fibrillation.
Okay, let's have a look at a couple of questions. So, as per the health pathways, advises to try digoxin if beta blocker not tolerated and not controlled at max dose of diltiazem. Can we try that in general practice? I guess we've kind of mentioned that a little bit.
Yeah, we've talked about that. I think if all else is equal, I would try a beta blocker first and then a calcium channel blocker second, and if neither of those were successful at that point, I would think about digoxin.
And so, yes, would beta blocker still be the first line in a younger male, age 50 years, with no other risk factors such as hypertension?
Probably yes. I would tend to favour it in that situation.
I tend to use beta blockers as well. So, but you'll see differences. You'll see differences. How do you prefer us to send an ECG to you from GP for acute review? Fax to hospital, electronic, or fax to the Auckland Heart Group, and to which specialist?
Yeah, so there might be another health board specific discussion to have. So we at Auckland Hospital don't have a formal, routine, regular ECG review system for the inpatient side of things. Again, you could call through to the on-call number and fax an ECG through to the registrar or consultant that's on call at the time. The system for that is somewhat ad hoc and a little bit hit and miss at times, I think, from our health board's perspective.
Yeah.
I'm not sure about yourselves as well.
No, I think it's probably better to try and send them through to the Auckland Heart Group.
Yeah, I think you probably get a better. I think you probably get a faster response, to be honest. Yeah.
Okay. All right, so if patient is already on a maximum beta blocker and calcium channel blocker, and what is the next management in a GP setting?
Yeah, so that's tricky. So I think the first thing to say is most patients can achieve rate control with these agents. The vast majority of patients can. So those patients who do not, the first thing I talk to them about is adherence to the medical therapy. But there is definitely a proportion of patients where either you can't get doses high enough to achieve rate control, either because of intolerable side effects to the medications, hypotension, dizziness, maybe leg swelling, maybe other side effects, in which case one might then think about digoxin, but that's when I start to think about, gosh, does one implant a permanent pacemaker and ablate the AV node and create complete heart block, such that the patient is then dependent on their pacemaker for their heart rate? That then allows the down titration and discontinuation of medication. So particularly where people are not tolerating medications, I think about that as a strategy. But it depends a lot on what the patient's symptoms are and what their heart rate is. I think targets for heart rate we should probably touch on as well. I mean, I think I wouldn't necessarily undertake a complete AV node ablation if somebody's heart rate was 90 or 100 if they were tolerating good medications. I think recent data suggests that we can allow a slightly more lenient approach to rate control. And maybe a resting heart rate of 100 to 110 might be reasonable, particularly if people are on higher doses. What's your approach to this?
I'm probably a little bit more aggressive. I think in the AFFIRM trials, even though they set a lenient heart rate control level, the actual median heart rate in the AFFIRM trials, most in the lenient control group were actually around in the 80s.
In the 80s and 90s.
Yeah, so I think I'd probably like to get it down under 100. Yeah, definitely.
Fair enough.
I think patients, as you allow them to get up to 90 to 100, I find that patients are often they might not say they've got symptoms, but they often do have symptoms. So, but each individual is a little bit different, and some people are truly asymptomatic at those heart rates, and if you're on a rate control strategy, I'm okay with that.
Yeah. So I think in that range, in that sort of grey zone between the two, if I can call it a grey zone between our opinions, I think that's where you manage the individual patient, and you take them at the there's still an art to all of this. There's not a definite science base to the whole lot.
Okay.
So the data from those trials are based on ECGs and Holter monitors, but an ECG or an apical rate, often the peripheral radial rate can underestimate the true heart rate, so an apical rate I think would be a reasonable surrogate for that.
The other thing is, you might have a rate that's controlled in your practice when the patient's sitting in your office, but actually when they walk outside and do a little lap around the car park and come back into your office and the heart rate's 150, 60, 70, or if they just walked into your waiting room, out of your waiting room and it was 150 or 60, I would say that that's not good rate control.
Correct, I agree.
So you just got to be careful that, that the rate control may not be that may be good in your office when the patient's sitting there quietly. So, just even a simple stroll around the block can be just useful for you to get a feel, because if the rate control, maybe if you'd accept around 120 beats a minute, with a little bit of gentle exercise, but if they did a little bit of exercise and the heart rate's up around 160, 170, you say, oh, maybe you're not doing so well. So it's important to maybe assess what the rate control is with a little bit of exercise.
Agree, and I tend to accept slightly higher heart rates in those patients who are dominantly sedentary. So those elderly persons who are relatively sedentary, and certainly those people who don't actively do exercise or what have you, I would tend to accept a slightly higher heart rate. But yes, we need to realise that our patients aren't sitting in our waiting room or having ECGs lying down flat as their baseline state for the whole day, and we need to assess their physiology in those settings as well.
Okay. So shall we move on to risk of stroke and the need for oral anticoagulation, because there's some interesting changes with the drugs that we have available. So I think we've probably covered what's on the screen there, don't you think, Andrew?
I think so as well. And the same with rhythm control. We've briefly talked about some of these agents, but I think from my perspective, the key thing with thinking about these agents, all of these are associated with some risk. And slightly higher risk of adverse drug effects than what we see with standard beta blockers and calcium blockers. In my opinion, the majority of patients who you're thinking about starting these on should be done in conjunction with a cardiologist. Is that what's your theory?
Yeah, absolutely. And so I think you should probably have a cardiologist review. I don't think these should be started out in your general practice, the flecainide, sotalol, and amiodarone. Flecainide and sotalol, I think flecainide, I think patients need to be coming back and seeing us regularly while they're on flecainide. I don't think if you've got patients on flecainide long term and they haven't come and seen us, for 3-4 years, they should probably come and get a check, because as you can see on that table, a void with hypertension, with a thick heart, impaired LV function, congestive heart failure, that flecainide can be pro-arrhythmic in these circumstances.
Correct.
And we'd like to be seeing those patients and making sure there's no underlying coronary artery disease developing. And
we know our patients don't stay the same with time, that things evolve and change. They develop hypertension, they develop left ventricular hypertrophy with that. So it's a dynamic, moving process as well. And these agents are very good when one is aiming to try and maintain sinus rhythm. But it's remarkable how often people that you're aiming for sinus rhythm will then develop persistent atrial fibrillation, perhaps on one of these agents, and be asymptomatic, in which case it's important to reassess and to say, well, a rhythm control strategy is no longer the aim for this person, but we need to stop that and therefore switch to just a beta blocker or calcium blocker and aim for a rate control strategy. So it's the opportunity to evaluate whether this is still a safe treatment, but also whether it's the right strategy and right treatment for the individual patient. It does give us the opportunity for that. I tend to see these patients on these medicines every year or two, generally speaking, myself.
So there's a question here, a patient on digoxin need regular serum level checks? I think the answer to that question is yes, because I think if you're developing digoxin, and the top level of the therapeutic range that's given on the lab reference forms is 2, but really I think we should be trying to get that therapeutic range level down to 1.2, because I think we know that you're more likely to get arrhythmia and an adverse outcome if it goes above 1.2. Yeah. So we want to try and keep the digoxin levels low, the drug dosing low. I think I probably wouldn't be giving patients more than a PG dose or 0.125 milligrams of digoxin in general. So maybe that's an answer to that question. And there's a comment about rate control with sotalol compared with metoprolol. Now I think we're probably if you're aiming for a rate control strategy, we're switching off to metoprolol, because sotalol has this issue with being renally excreted, and in elderly patients you can accumulate sotalol, and the other thing is the issue about prolonged QT interval with sotalol therapy.
Yeah, that's absolutely correct. So I have caution with sotalol in terms of its ventricular pyrarrhythmia risk, and that's mediated by QT change and QT prolongation. And that can be quite dynamic, and particularly if people develop acute renal dysfunction, say with a diarrheal illness, for example, concomitant non-steroidal use. The QT change with sotalol can be quite dynamic and can change quite quickly. So if I'm aiming for a rate control strategy, I will quite quickly change off sotalol and onto a conventional beta blocker, such as metoprolol or bisoprolol, and I don't use sotalol as a rate control agent in that setting because of those reasons.
Okay, let's move on.
Okay. So we're talking now about stroke risk, and so CHADS-VASc risk. And so CHADS-VASc is something that you're probably all very familiar with. It's something that has become very commonly used as a stroke risk judge in the recent past. This may or may not change. Last week at Cardiac Society's meeting talked about a gender-neutral approach to the CHADS-VASc calculator, so removing female gender from calculators and the like. That might be part of the sort of current Me Too things, but we'll not talk about that.
I think that's controversial, so I think we'll stick with this.
Yeah, absolutely. So I'll stay on task.
So, Andrew, do you want to talk a little bit about your rule of thumb about CHADS-VASc? I mean, it's hard to remember these 1.3s and 2.2s.
Yeah, correct.
And, in terms of CHADS-VASc score, what's your rule of thumb on that?
So the rule of thumb when I talk to patients is for each of these risk factors, there's an approximately 1% per annum risk of stroke risk associated with atrial fibrillation. So if somebody has, you've got a patient who's age 70 with hypertension, they've therefore got two risks. So that first risk being age between 65 and 75, second risk being hypertension. So two risk factors. Roughly speaking, in my mind, I think that's approximately a 2% per annum risk of stroke. If you have three risk factors, so same patient with hypertension, when they turn 75, that's 2 points. So therefore, they've got a CHADS-VASc score of 3, so roughly a 3% per annum risk. I think that score works out pretty well, that sort of rule of thumb works out pretty well until the score is more than 5 or 6. But in truth, most patients that we see have scores of between 0 and about 5. So I think that's a useful thing to have in one's mind when talking with patients and when considering the risk and balance, the risk-benefit and balance of oral anticoagulation therapy. These days, my current practice is to commonly use oral anticoagulation, particularly if people's scores are more than 1. Routinely, if it's more than 2, would be when I recommend it. But if it's more than 1, I'm very happy, and I'm certainly leaning towards people with stroke risks of 1% or more per year due to atrial fibrillation, recommending and certainly offering them oral anticoagulation therapies. What's your practice from that point of view at the moment?
I totally agree. I think it's equivocal when the CHADS-VASc score is just 1, and don't forget that the female, even being gender, if it's just being a woman, doesn't count as a single 1 point. It has to be in combination with others. And the second point is, so it's a matter of discussing the risks and benefits with the patient, but certainly absolutely 2 or more. I'm very keen on anticoagulating patients.
Yeah. And I think when we talk about the risk side of oral anticoagulation, broadly speaking, these large trials that have been recently published, and I guess with rivaroxaban coming to, from Pharmac's perspective, being available now to prescribe, we're talking roughly in the order of 4 or 5% per annum major bleeding risk with these agents. And clearly stroke is a potentially life-threatening, but often life-changing event. And so when one balances these things, I don't see one bleeding event as being equivalent to one stroke event. I certainly see one stroke event as being much worse than one bleeding event when I talk with patients about this. How do you juxtapose those?
Well, I think it's just the serious bleeds are actually not, are not that common. I mean, even though you say there's a bit of bleeding, they're minor bleeds, or they're
not life-threatening bleeds.
They're not life-threatening bleeds. Yeah. So, and certainly with the newer novel oral anticoagulant agents, the risks of intracranial hemorrhage and major bleeding is much less than warfarin, and that's why we're predominantly have gone absolutely towards saying patients should be on a novel oral anticoagulant. Should we look at the next slide? Yeah,
absolutely. So this is talking about, so now we have rivaroxaban available to prescribe, which is a great addition to our armamentarium. So we've learned over the last 6 or 7 years or thereabouts about dabigatran. So I've always considered warfarin to be the devil I know, and dabigatran's now the devil I'm getting to know quite well, or I've gotten to know quite well. And there are definitely some pros and cons to dabigatran when we consider it in comparison to warfarin. We know it's renally cleared, and we know that we have to be cautious in our patients with renal dysfunction, but we've certainly learned that the dyspepsia and the GI upset risk with it is a real phenomena. Approximately 1 in 5 patients find this to be a real challenge, and we've all got strategies such as taking it with meals, maybe taking it with quickies or milk or all those sorts of things to try and help this out. But for some patients it remains a real issue and a real challenge. Now, rivaroxaban we prescribe once daily, and the dosing of which is really based on renal function. So we give 20 milligrams a day for those patients with absolutely normal renal function, and for those people with mild to moderate renal dysfunction, so it's EGFR 30 to 50, we reduce the dose down to 15 milligrams a day.
So I was going to ask, in the audience, and in terms of general practice community, have you heard about the fact that rivaroxaban is a new novel oral anticoagulant agent? Who hasn't heard about rivaroxaban? Yeah, so this is, it's been used for DVT and PE, and so the dosing is slightly different, isn't it? Because in the DVT-PE side of things, they often start off with twice a day rivaroxaban for 6 weeks, and then they go onto a maintenance dose.
Yeah.
Whereas the dosing for rivaroxaban and atrial fibrillation is purely once a day. So that's just something to point out.
Yeah.
That may help patients with adherence. I mean, it's obviously been approved by Pharmac just from the 1st of August, so I guess we're all kind of going to get used to using it in atrial fibrillation, but what would you do?
Yeah, certainly one of the cautions that I have when considering rivaroxaban is its once daily dosing with a short half-life. Now, it does make me think that if people miss a couple of days worth, that their protection, so to speak, from a anticoagulation point of view might be impaired, and that might be more so than with dabigatran. Certainly we know that people can miss a dose or two of dabigatran and still have an effective anticoagulation risk, and missing a single dose doesn't seem to be associated with an increased risk of stroke with dabigatran. We don't quite yet know that information with rivaroxaban, but that might be something to learn in the future as time goes on and as our experience grows with it. I'm probably still going to use dabigatran commonly, and certainly for those people who have dyspepsia, I've got a few patients lined up at the moment that I'll be switching over that are finding it really tough but would much rather take dabigatran than go to warfarin for various reasons. Those are people in the first instance that I'll switch over onto rivaroxaban. I guess those people who have had a history of dyspepsia, what have you, I might think about using that in the first instance. So it's really that side effect profile and patient-centred.
Yeah, I think if patients have got very bad dyspepsia or gastroesophageal reflux disease, maybe patients got limited scleroderma, or those sorts of patients who'll be at high risk, for getting the dyspepsia, I might just go straight to rivaroxaban than dabigatran. The older patients, renally excreted, patients over 75, I'd probably still stick with 110 BD of dabigatran. What about the food? It's got absorption reduced, 15% if taken without food. Yeah, so how do you read that?
Yeah, so the initial pharmacokinetic data suggested that rivaroxaban is absorbed as a lipophilic profile, and that absorption seemed to be reduced when people took it without food. That was the initial pharmacokinetic data, and I'll be recommending that people take it with meals, and ideally a larger meal rather than a small meal. The Rocket study didn't really talk much about whether it was taken with food or not, and the prescribing sheet that goes with this doesn't talk so much about the food. It says can take with or without food. But the initial pharmacokinetic studies did talk about this, and so I tend to recommend this to my patients, that they take it with a meal rather than without food.
What about antidotes?
Yes, there's not yet an antidote for this. As you probably know, there is an antidote for major bleeding associated with dabigatran. Idarosuzumab is available, and it's present in all of the major metropolitan hospitals in Auckland. It's present in the blood bank, and it reverses dabigatran's effect really fast. It's within 5-10 minutes. You completely reverse the effect of that. It's even faster than the reversal for warfarin. Now, there's not yet a commercially available antidote for rivaroxaban. There's been one in trial, and it might well become commercially available at some point this year or next, but there has been trial data to that, so it's on the horizon.
Yeah, I personally don't see that as a limiting factor, to be honest, the antidote issue, because I think the risk of major bleeding is not high, and there are prothrombin complex reversal agents that can be used.
Correct, and it didn't seem to stop us too much when we first started using dabigatran.
No. And the other thing is probably aspirin. Now, we should probably comment about aspirin and stroke prevention.
Yeah.
No role?
I don't think there's a role. I no longer see a role of aspirin in stroke prevention. It's fallen away from European guidelines. The efficacy rate is much less than these novel agents. There has been one novel agent, apixaban, that's been compared with aspirin, and the bleeding rates were the same between those two, and certainly the efficacy of aspirin was much, much less. It's difficult to stretch across these trials in terms of these novel agents, but overall it does look as though the bleeding rate with aspirin is similar to these novel agents, but the efficacy is much smaller.
Just to point out, rivaroxaban, you can prescribe it. No special authority required. So, you know, if you have your patients on dabigatran dyspepsia, you can actually prescribe the rivaroxaban and switch them over. How are you going to switch them over, Andrew? So you're on dabigatran 150 BD.
Yeah.
My thought is that, you know, they can take the evening dose of dabigatran and then you can start the rivaroxaban the next day, right?
That's how I'm going to do it.
Yeah. So there shouldn't be any problem switching them over.
Yeah.
What about warfarin?
Yeah, I'd wait until the INR is less than 2 before starting rivaroxaban myself.
Right. So check the INRs, make sure that they're falling down into the lower range before you start rivaroxaban.
Yeah. Any other questions before?
Given risk of GI bleeding in over 65s on oral anticoagulants, should they all be on proton pump inhibitors?
Ooh, it's reasonable to consider that, but I've not done that routinely myself. I'm not aware of any evidence base to show that that's an effective strategy at preventing GI bleeds in a truly prophylactic population-based setting. And there are some potential important side effects associated with long-term proton pump inhibitor, such as renal dysfunction, so I don't tend to do that myself.
Should I be concerned about stopping NOACs if NOACs are being used for patients with atrial fibrillation, they're going to go for a colonoscopy or gastroscopy? Should I be worried about, you know, bridging or, you know, stopping the medication? Usually for pretty much anybody with atrial fibrillation and NOACs, I actually have no issue with stopping the NOAC and just letting them go forward and have their procedure. I think the risk of them having a stroke in the intervening period before their colonoscopy or gastroscopy is going to be exceedingly low. What do you think?
I think the same. I think for the vast majority of patients that they can pause their NOAC. We're thinking about this. If we go back to the CHADS score and think about that for a moment, you take a CHADS VASC of 3, that's a 3% per annum risk. It's not a 3% in that one week. Probably the group of people where I would take an opposing view would be those patients who have recently had a stroke. I think if you've had a stroke due to your atrial fibrillation within the past 2 to 4 weeks, we know that those people are at higher risk of having recurrent thrombosis, and I'd be quite reticent about pausing anticoagulation in the month or 2 months or so immediately following a stroke. But for the vast majority of our patients, we're doing this as primary preventative treatment, trying to stop them from having their first stroke.
So patients might be in your practice and they're on dabigatran and aspirin for AF stroke prevention. I mean, I've been stopping the aspirin in all these patients.
Likewise, yeah. I mean, I guess what do you do if they've had a stent recently?
I think, yeah, that's a good question. So you'll find that patients, you know, you may see the situation they've had a stent for coronary disease put in. They come in, they come out, see in the practice 3 to 4 weeks afterwards. They're on all 3 aspirin, clopidogrel or ticagrelor and the dabigatran, but that's we know the bleeding risk is quite high in those patients if it's prolonged, but those patients often keep going for 6 weeks. They tend to come off the aspirin after 6 weeks, and then after a year they're just onto the Pradaxa or rivaroxaban.
Yeah, so it's about having a close relationship with our interventional colleagues and a planned strategy for the discontinuation, because it's about risk and benefit up front in terms of stent thrombosis and bleeding risk. And most of these patients need that triple therapy for only quite a short and defined period of time, and we can start stepping those other agents off as time goes on.